الصوت شغال.
ماشي يا فندم.
صح.
واحنا كل الناس دخلت خلاص الغرفة. تمام.
طيب. Again, in one sentence, when a patient has normal pentacam, this may mean that this patient has normal biomechanical properties. The term biomechanical properties is referred to as the corneal hysteresis and the corneal resistance factor, which is related to the corneal or expressing the corneal power under the intracorneal pressure. Okay? So the patient with normal pentacam could be with normal biomechanical properties, but it's not a must. So this patient is not 100% protected against ectasia. But it's still important for every refractive surgeon to focus and check the corneal biomechanical properties to complete his own tools for studying the risk assessment for that patient. Patient may have a normal topography or normal pentacam in general, but he may have abnormal corneal hysteresis. So if you have abnormal corneal hysteresis in this patient, even with normal topography and normal tomography and normal pachymetry, you have to exclude or think again about this patient because one of the main tools is not provided or it's not available in this patient. So again, after 10 years of fading out of the corneal biomechanics, we are coming back now to put it in focus again. The last week, I have met Professor Ambrosio 3 times. And every time he is repeating the corneal biomechanical properties is included in the new modules for studying the risk assessment and the patient's susceptibility to ectasia. In the BAD, which is the Belen Ambrosio display, which is 10 years old now, he said that the corneal biomechanical entity is added to a new module. It's called the BAD-D and BAD-DI, which is the new adjustment of the old BAD display. Because they found that the corneal biomechanical properties may support you to go for refractive surgery or may lead you to discharge this patient and cancel thinking in the refractive surgery, in the corneal refractive surgery, because the corneal power is very important and a crucial issue in deciding the refractive surgery. I know in Egypt, we don't have in all centers the devices for the corneal biomechanical studying, which is the ocular response analyzer or the Corvus standard. It's not available everywhere. And we are judging our patients through this for composite map and the screening display, either with the Holland report or with the Belen Ambrosio display in the wave light. But we are still not sure 100% that this patient is completely normal. The maps are normal, but this doesn't mean that the corneal power of this patient is normal. So if you suspect any patient, if you have any mild risk, you have to send this patient to get aura or Corvus to study the corneal biomechanical properties for this patient, which will support you. If you have a mild risk in the topography, which may be related to surface irregularities or surface abnormalities or false negatives, false positives, you can have another proof that this is the background, and we have to care about the corneal biomechanics again and to consider it. Okay, the risk assessment for any patient includes 2 parts. The first part is studying the surface maps and studying the corneal power زي ما قلنا في the last slide. Surface map, it's pentacam, and the corneal power is the corneal biomechanics and intraocular pressure. So the surface map is topography, elevation maps, and thickness map. And the corneal power related to the error of refraction, the biomechanical properties, intraocular pressure, and associations related to the corneal tissue itself. If there is a scar, if there is thinning, if there is a corneal post-trachomatous pannus, if there's corneal vascularization, the old tissue changes. The histology of the cornea may affect the corneal power and at the same time affect the images of the surface maps too. So the intracorneal pressure is a very important factor to measure and to study and to compare and to correlate the intracorneal pressure with the central corneal thickness in the pachymetry map. So may correlate to each other, and getting the intraocular pressure with the cornea compensated from the aura or from the corpus to know about the corneal power. The corneal power is related to the intracorneal pressure and the reverse. And so this red arrow is pointing from the left side to the right side, that both are correlated to each other. It's one unit, it's not separated. There is apparent risk factors in the maps. Let's study the first one, the topography. But when you have any topography or the pentacam maps, you have to check first the reliability of this test, if it's reliable or not. If the patient acquisition is good or not. The first point to start studying it, to be sure that it's reliable. Otherwise, you will ask for recapturing again. If there is misalignment, if there is deviation of the eye, if the patient is not concentrating properly with the in the target point in the device, you will check all of that to get reliable. The second point is the Q value. The Q value, you will find that the Q value in the right side and in the bar of the printout from the pentacam, either in the right or the left with the data of the patient, you will check the Q value. The Q value, I will show a paper about it after in the coming slides. So you will check first the topography, which is the sagittal curvature map, to know the key reading, the Q1 and the Q2, the steepest and the flattest Ks, and the relation between the Q1 and the Q2. On studying the corneal front, the corneal topography, you will check that the steepest K is in the normal range. What is the normal range for the steepest K? So the steepest K reading should be less than 48 or equal to. Should be equal to or less than 48. If more than 48, you have to suspect this patient, especially if there's no pathology in the cornea explaining that. You may have a point with very steep K, but it will be explained clinically on the slit lamp by a scar in this cornea. So if you can explain this point, you may go furtherly in studying the other parts, okay? But if you don't have any corneal scars, the corneal thinning causes in this cornea, you will consider this is abnormal steepening in this part of the cornea, especially if you have this steepening in the inferior part of the cornea. So if you look at this maps shown in this slide, you will see that the vertical meridian is the steepest meridian, and the points pointed in red from the superior part. The figures are 43 and the highest point, And in the central 6 millimeter, you will find that there is 45.1 in the superior point. Then at the center is 45.4. I'm talking about the picture on your right side. Okay. When you cross the center going to the inferior part of the bow tie, you will find that the figures is almost the figure at each point is almost the same at its coinciding point in the upper part. It's 45.6, 45.5, and 45.2. So we have to measure now the difference between the superior point and the inferior point in the central 6 millimeter of the cornea. You will find here that the superior point is 45.1, and at the same level, at the same circle, you will find the inferior point is 45.5. The difference is 0.4, just 0.4 difference between the superior and the inferior point, which is more in the inferior than the superior. This is called the IS, I inferior, S superior, I, or A. In some printouts, it's called inferior superior asymmetry, ISA, or the index ISI. So if there is a difference between the superior point and the inferior point with less than 1.5, you can consider that this topography is within normal. If more than 1.5, it will consider this topography abnormal or atypical, because there is inferior steepening of a difference of more than 1.5. Again, the superior point is less than the inferior point by less than or equal to 1.5. It could be accepted, especially if there is no other signs in the coming maps and the coming slides. If you just have this, it's accepted to get a difference between the superior and the inferior points by 1.5 or less. If more, you have to suspect. So the difference between the superior and the inferior, if the inferior is more than 1.5, the same point at the same level. If more than 1.5, you have to suspect. You have to put X sign on it and suspect this patient's topography. If the difference, the superior point is higher than the same inferior point, but up to 2.5, it could be accepted because of the superior corneal pathology, which is endemic in Egypt, which is the trachoma and post-trachomatous pannus and subepithelial fibrosis and the vascularization, which is common in the Egyptian patients. So we can accept up to a difference of up to 2.5. And there's a question here. What about the inverted conus? Do you believe that there's an inverted conus? About myself, there is no. I don't believe that there is what's called superior conus, because the ectasia process is the weakening cornea going to the inferior part of the cornea, not the superior. The pathological process of the ectasia is going to the inferior cornea, not to the superior, away from the gravity, away from the because it's not considered here the gravitation and so, but the main point is the eyelid dropping of the superior cornea going to the down cornea. Also the eye rubbing, if we consider that the eye rubbing is one of the factors for ectasia, the eye rubbing is moving the cornea from the superior to the inferior. So I asked many international refractive surgeons and the reviewer and interpreters for the conus about the inverted conus. They don't believe in what's called inverted keratoconus. But it may call it superior ectasia, the tooth thinning factor, which may cause thinning of the superior part with protrusion of the superior cornea, but not keratoconus. There is no superior keratoconus, and I respect all the authors and the professor that saying that there is what's called inverted keratoconus, but about myself, I don't believe in it. So I can consider a difference of up to 2.5 difference between the superior and the inferior. That is normal, especially if I found on the slit lamp a corneal pannus or subepithelial vascularization and fibrosis after trachoma. So to skip this slide, the lower one, I put it inverted to tell you that there is a difference between the inferior and superior. If we invert it, it will be accepted if the difference is more than 2.5. Finally, to summarize this slide, look at the topography. If there is a normal and regular and acute bow tie, like shown in these figures, you will find in the normal spherical cornea that the superior point is like the inferior points in the central map. But if there is a difference between both, it may be related to the conical, the non-smooth, it's not completely smooth surface of the cornea, that there is a difference between the superior and the inferior, because it's normally the inferior cornea somewhat steeper than the superior cornea because of the pressure of the upper eyelid, which is more than the lower eyelid, because the lower eyelid doesn't touch or doesn't press on the inferior cornea. So there is some flattening in the superior part of the cornea in relation to the inferior part. So the difference is accepted in the inferior up to 1.5, in the superior up to 2.5. And don't forget all the time that the clinical correlation is so important. Don't forget that you are an ophthalmologist. There's a vertical and there is a horizontal meridian. The difference between both will express the corneal astigmatism, the anterior corneal astigmatism. We missed it. The corneal skewing is very important sign to consider or to suspect a keratoconus, abnormal topography. The skewing that this topography, which is shown in the slide, is a perfect typical one. The vertical one is steep, the horizontal one is flat, and the angle between the vertical and the horizontal is 90 degrees, is a perpendicular angle. It is the normal astigmatism with rule. So if there is any deviation of one of the lamps of the bow tie, especially the superior or the inferior one, and there is an angle between them which is more than 15 degrees, you may suspect. If this angle between the superior and the inferior lamps of the bow tie is more than 21 or 22 degrees, you have to highly suspect this patient that there is corneal abnormal points. Where please don't worry about the superior steepening. The most worrying is the inferior steepening. وبالمناسبة I asked Ambrosio يعني if you wanna listen to all these questions, it's shared on the YouTube on my channel. But I asked him about the superior keratoconus. He said there is no what's called superior keratoconus and what's called inverted keratoconus, but it's ectasia. And the two terms are different. Keratoconus is one of the ectasia, but it's not the complete name of ectasia. Ectasia doesn't mean all the time keratoconus. Keratoconus is one entity of the ectasia. Ectasia means protrusion in the weakness of the cornea and the protrusion of the cornea. So as I said before, the thinning of the superior cornea with protrusion, it means ectasia and not keratoconus. But you have to see on the slit lamp the ultimate thinning, the real thinning, not just scarring or not just pannus. If there is a normal thickness in this point, and there is a steepening higher than 49, even 50, I will go for refractive surgery without any worry. Let's go to the elevation map. The
محمود
elevation.
انت حضرتك عندك سؤال دكتور محمود خليل؟
ايوه
اتفضل.
دكتور حسام.
دكتور حسام معاك دكتور محمود خليل.
اتفضل يا حوت.
معلش عملنا لك انترابشن يا دكتور حسام.
لا يا اخي حبيبي خالص معاك.
What if I have a patient with regular butai and I don't have any inferior superior asymmetry, but I just have a steep cornea with a K reading more than 48? Do you go for any type of ablation like surface ablation or anything, or you will hold to ablate this patient?
You mean that we have a steep point but superior or inferior?
Steep butai. I have in the upper part a point of 40. Yes, but no inferior superior asymmetry, just steep butai with patient with high astigmatism.
Yeah.
Do you will go for ablation or not?
Yeah, if we consider this patient as a steep normal cornea,
yeah,
I will go for a flap related flap including procedure. I will ablate. You will be you will be worried about the buttonholing. The buttonholing on doing the microkeratome. To be safer, you may go for the femtoflap. You asking.
No risk for ectasia, Dr. Hassan.
You are asking about the ectasia or the flap-related complication.
Yes, ectasia.
Ectasia.
No, ectasia. No risk. Is there any risk of post-LASIK ectasia?
Regular cornea, symmetrical cornea, regular and symmetrical, but the steepest K is how much?
Say 49.
49, and the old figures in the maps are okay, and we'll assume that the corneal biomechanical properties are okay.
Yeah,
the same, and the patient's age is okay, and the refraction is high degrees of myopic astigmatism, right?
Yes. Yeah, right.
Okay, if we have all the points normal, I will go for refractive surgery, and I have done a case with K reading with a steep K of 49. I have done LASIK for this patient 10 years ago, and she's okay now until now.
Alhamdulillah.
Okay, alhamdulillah.
The point here that no patient is protected 100% from ectasia, but you have just to be assured about the all points needed to do the surgery.
Yes.
As we are saying all the time, there is no what's called the must or the 100%. The 100% assuring science, but at least for your patient to be away from the suspecting points. لو الكي reading regular, لو البوتاي regular, والكي reading within the normal range اللي هو 49 in some authors and some publications up to 49. Others may follow the 48, but I'm with the school that are following the 49. So you have the 49 regular, no difference, no problems in the elevations of this patient, the stable refraction and good vision, the best corrective visual acuity is good, and the age is good, and the follow-up period before going for the surgery is good. You can go for surgery without fear. But about the flap, I will go to flap if I could
for safety,
protect myself from the buttonholing.
Yes.
Okay, we will go now to the second point, which is the elevation maps. After studying the curvature map, I will go to check the elevation map the anterior elevation and posterior elevation, anterior surface and posterior surface. And both are separated. It's not related to each other up till you have a suspecting point, and you will try to correlate the surface, anterior surface to the posterior surface in the same point. The anterior elevation is assumed normally to find that it's higher in the inferior than the superior, for the same reason we talked about for the topography itself, because there's accepted inferior steepening, there's also accepted increased elevation in the inferior part of the cornea than the superior part. What is the normal anterior elevation? It could be a normal up to +7. If you find a point +5, +6, +7, you can consider this point as a normal. Beyond +7, you will suspect. If you find that a point more than +12, you have to highly suspect this patient or this anterior elevation. You will put a sign on it. There's abnormal anterior elevation here in this point. Then go to the posterior elevation to check for the old and to check for the posterior elevation at the same point of the increased anterior elevation. The posterior elevation in the central 6 millimeter point of the cornea, it could be accepted as normal up to +15. Beyond 15, you may suspect there is abnormality. Beyond 21, beyond +21, it's highly suspicious, and you have to suspect this patient and think in refractive surgery again. Especially if you found that the high anterior elevation point is similar to the high posterior elevation in that patient. This is a protrusion. It is a whole protrusion of the cornea, posterior surface or the anterior surface. And go to the topography. If there is steepening at that point, you will put the old equation of the Holland reports. The Holland reports coincide that the keratoconus could be suspected or diagnosed if you found that a point of steepening, at the same point there's anterior elevation higher than normal, and at the same point there's posterior elevation higher than normal. And this, at the same time, there is thinning in the pachymetry map at that point. So if the all maps have abnormality at the same point, it's diagnosing. This is diagnosing keratoconus. And this is called Holland report or Holland rule. If you look at this map, you will find that the anterior elevation, it is not present here in this map, but here there is the elevation back. Just I will show another slide with the anterior elevation. You will find that on the right side, the anterior elevation, the posterior elevation of +33. It is the highest point, which is at the central part and significant zone of the cornea. So it's highly suspicious. Around there is +10, -7, 0, +2, -10, and so. And there is what's called a tongue-like protrusion in the back of cornea. So these two signs, the tongue protrusion and the very high posterior elevation in this point is highly suspicious, and you will correlate it with the sagittal curvature here. You will find here in the sagittal curvature for the same patient or for the same eye is 44.8, which is not steep. Then the coinciding point in the superior part, which is 45. Okay, but
we had عنده سؤال على الشات يا بروف. بيقول لحضرتك على الشات حضرتك.
okay. Okay, but if we
انا بسال بس يا دكتور حسام، في فرق بين الاليفيشن بوينتس بين الهيستوريك اليبسويد؟ اعتقد ان الارقام بتختلف بين الاثنين.
yes في طبعا فرق ما بين البيست فيت سفير وبين الابسايد فيت سفير ماب. but the commonly used is the best fit sphere, which is easier and simpler than the ellipsoid map, which is used in case of a high astigmatism. If any patient with high astigmatism okay, thank you. If we have a high astigmatism, we may consider in cases of suspected maps we have to consider. معلش أنا آسف. Just a second. محمد.
اوكي اعمل ميوت يا فندم. حاضر.
No.
اوكي.
معلش بس الولاد حابين يشاركوا معايا.
لا مفيش مشكلة يا بروف.
We have the best fit sphere is the common map used for all. But in case of high astigmatism, if we have any abnormal maps, either the curvature map, which is the topography, or the elevation, we put it on the ellipsoid fit sphere. Okay, the ellipsoid map to remove the factors, or to check for the factors which may be caused falsely by the astigmatism itself, because we have a lot of false high elevation with the astigmatic cornea. So it's calculated in the ellipsoid map to remove all these affecting factors. But the best fit sphere is the commonly used rule or map for the elevations. Okay, Ahab?
اوكي يا باشا. اوكي.
دكتور عمرو راضي يا باشا عنده سؤال ممكن؟
اوكي اتفضل.
السلام عليكم.
اتفضل يا دكتور عمرو.
السلام عليكم. اتفضل يا عمرو.
بعد حضرتك يا فندم، بس بالنسبه للإليفيشن مابس، هل في فرق بين الارقام دي في حالات الميوبيا او الهايبرمتروبيا؟ لان انا كنت قريت يعني ان في الميوب الانتيرو إليفيشن لحد 8 والبوستيرو إليفيشن لحد 18، وفي الهايبروب لحد 7 في الانتيرو إليفيشن ماب، وفي البوستيرو بيبقى لحد 28. برضو يعني ايه تفسير الارقام دي او الاختلاف بينها، ورأي حضرتك برضو فيها ايه؟
حاضر. يعني going back to the same the same question of Dr. Ihab Tharwat, normally the normally or the commonly used is the best fit sphere, which is the symbol line. There is an imaginary, it's an imaginary line from one pole of the cornea to the other one, and so the point of the back of cornea in front of it is expressed by plus, and the point back to it is expressed by minus. So there is protrusion or the recession or decision back. Okay, this is the best fit sphere. If we have any abnormality in the elevation map, we have to think there is abnormal, really abnormal, or there is other factors affecting this map display. If there is high astigmatism, the astigmatism itself, because the difference between the two curvatures of the cornea, it will convey some refraction, or it will interrupt the path of the rays. So the astigmatic cornea may show abnormal elevation maps on the best fit sphere. So it's calculated by the module is called ellipsoid map. In cases of hyperopia, there is higher posterior elevation points or figures than present in the spherical and in the myopic, because of the nature of the cornea, especially if the corneal, especially if the hyperopia is related to the cornea, not to the axial length of the eye. If it's curvature hyperopia, not axial hyperopia. So there is a program calculating and treating that in all machines and most of machines to calculate the elevation maps for the hyperopic patients, especially in the display of the Pellin-Ambrosio. You may find a point for the myopic and the another calculation for the hyperopic. But actually the posterior elevation points in the hyperopia is like the myopia, but it is the margin of suspicion. It could be normal up to +15 in both myopic and hyperopic. And in the range, the margin from +15 to +21, it could be suspected, but it's more accepted in the hyperopic more than the myopic. But beyond the 21, it's abnormal. It's not accepted in both because of the type or the amount of refraction of the rays coming from the machines related to the curvature myopia and the curvature hypermetropia, the nature of the refraction of the light in both corneas. معايا عمرو؟
تمام يا فندم، متشكر جدا.
Again, +15 is a point of acceptance. Beyond, some authors said that +18 is the margin of acceptance in the myopic and +21 in hyperopia. But actually the margin from 15 to +21 is accepted in both, but no, it's highly suspicious in both, but it could be accepted in the hyperopic more than the myopic, especially if the other points are within normal. There is no other risk factors in this patient. Okay.
اوكي يا فندم.
Thank you. Here the elevation map on the left side within the normal range +4, +4, +3 in the normal in the central significant circle of the back of cornea, while on the other eye it's out of normal +33, but we have to correlate the point here in the elevation with the sagittal curvature and the thickness map. And also the deviation of the thinnest location, which I will show in the pachymetry map. Before going to the pachymetry map, the elevation map, you will study the numbers and the sign of the numbers, plus or minus, and the correlation between the posterior and the anterior elevation with other figures. Also the appearance of the color code scale of this patient. If there is a tongue, a protruded tongue in the back of cornea or on the anterior of cornea, you will suspect that, because we may find points which are in the normal range or the accepted range, but actually they are all borderline. If you find that the all borderline, go to the topography again. If there is any abnormality in the topography, and go for the deviation of the y coordinate, the deviation of the thinnest location. If you find that all of them are borderline, you have to suspect this patient, because this patient could be forme-fruste choroiconus. The forme-fruste choroiconus is diagnosed when you have atypical, when you have abnormal topography with a borderline maps in the pachymetry map and the elevation map. If you have a borderline figures in all with abnormal topography, you have to suspect this patient as a forme-fruste chronic patient, and don't go for any refractive surgery, even the PRK. But if you have it all borderline with normal topography, you have to You can go for refractive surgery in such patient, but take the safety margin by going for the surface ablation, not not to cut. You can, but you shouldn't. What you shouldn't do to be safer, on the safer side. Now we have to study 3 points in the pachymetry map: the thickness at the apex of the cornea and thickness at the thinnest location. About the first one, the thickness value itself, and the relation between the apex of cornea and the thinnest location, and the location of the thinnest location from the apex of cornea, the deviation of the thinnest location. Normally, the thinnest location should be at the apex of cornea. If it's shifted away from the apex of cornea, you have to consider the difference, and you have to consider the distance between these 2 points. We have vertical deviation and horizontal deviation. Which of them is more important? The vertical deviation is more important than the horizontal deviation, because the behavior of the corneas is inferior, especially infranasal in HI. So the inferior or the vertical deviation is more important to consider than the horizontal or the superior deviation. So study here the thickness. The thinnest location in the cornea should be more than 490 to think in refractive surgery. 490, this is the school I'm following. Another authors are saying that the cutoff point is a 500 micrometer. Don't go for refractive surgery or flap containing refractive surgeries if the thinnest location is less than 500 micron. But I'm supporting the opinion or the view that the 490 we can go for refractive surgery if the thinnest location is 490, provided that all figures are okay. We can consider this cornea that a normal thin cornea, because of the average of the cornea thickness is around 550 micrometer. So if you have a thickness of 490 micrometer in the thinnest location, you may think in refractive surgery. If less than 409, down to 465 or 470, with all figures are okay, you will consider that this cornea is normal thin cornea and you can go for surface ablation. So the limits, 490 or more, other figures are okay, you can go for flap. You can cut and go for refractive surgery. Less than 490, down to 465, and normal elevation, normal topography. This is normal thin cornea, but not to weaken it more, go for PRK. If less than 465, and normal cornea even, don't go for any ablation. Think in another option like the phakic ILs. So the thickness, 490 or more, PRK down to 465. Okay. The second point to study in the pachymetry is the relation between the corneal apex and the thinnest location, which is called the Y coordinate. The Y coordinate is a deviation of the thinnest location from the corneal apex, which should be less than -1. But you can accept deviation of less than or equal to -0.5. If the deviation is -0.5 or less, you can accept, but still suspecting. But if more than -1, more than -0.5 to -1, highly suspect. If more than -1, don't do any refractive surgery, because it's one of the signs of the corneal shifting and the corneal protrusion and the corneas. The deviation is vertical and inferior. But if the deviation is vertical and superior, you can neglect this deviation because of the matters or the causes we talked about in the slide of the topography. The thinning, the superior thinning, the two panels or scarring or other, you will get the thinnest point superiorly. Will take the deviation of the thinnest location away from the corneal apex, but in the superior part of cornea at the same point of steepening. This is the thinning of the superior cornea, which could be neglected if the other factors are, as I said, as I answered Dr. Mahmoud Khalil before, if there's no correlating weakening factors in that cornea, and the thinnest location is superior at the same point of steepening, you can go for refractive surgery without any fear. Also, the horizontal deviation, it may be expressed by scarring in the peripheral and the mid-peripheral cornea. But the most important deviation is the vertical inferior deviation of more than -0.5. You will suspect more than -0.5 and don't do any surgery if more than -1. The third point is the difference of thickness between the corneal apex and the thinnest location. The difference between both shouldn't exceed 10 micrometer. If the thinnest location, as shown in this figure, the Pachy apex is 557 and the thinnest location is 504. The difference is too high. Is more than 50 micrometer difference between the apex and the thinnest location. This cornea is highly suspicious. And also the deviation here, which is signed by the red circle, red oval, the y deviation, the y coordinate is more than -1. It's -2.3, and vertical and a vertical inferior more than -1. And the thinnest location between the difference of thickness between the apex and thinnest location is more than 10 micron. So this pachymetry map is highly suspicious and is abnormal map. And this patient is not candidate for refractive surgery. And I'm sure that you have to find abnormality in the curvature map of this patient. And if you got the corneal hysteresis of this patient, you will find it below normal. Also, the scale, the color code and color scale of this pachymetry map, it's dome shaped. This dome shaped pachymetry map is a figure, a suspecting figure. Before studying the numbers, you may suspect this patient from this shape first. Okay, before I'm going to the clinical cases, any question about the pachymetry map? Hello, guys? Hello?
دكتور حسام معنا دكتور عزت عنده سؤال.
طب اوكي about the pachymetry map كل حاجه كانت مسموعه كويس؟
أنا كنت سامع كويس. دكتور عزت معانا. اتفضل يا دكتور عزت.
دكتور عزت نبيل.
اتفضل يا دكتور عزت.
السلام عليكم دكتور حسام.
عليكم السلام كيف ازيك يا عزت حبيبي؟
الله يخليك يا ربنا يخليك. سؤالين يا دكتور حسام بالنسبه للموضوع الباكيمتري المسموح ان انا اعمل فيه ليزك او بي ار كي. حضرتك قلت اقل من 465 ما بنعملش اي حاجه خالص. طيب في المساحه ما بين 465 و 490 هل الاماونت اوف ريفراكتيف ايرور بتتحكم اعمل ولا ما اعملش؟ يعني لو عيار 70 ماينس 2.
اوكي عايز ابص دي هنحسبها في البي تي اي والريسيدوال سترومال بيد in the coming slides.
يس.
اوكي.
في سؤال ثاني يا دكتور حسام.
يا حبيبي اتفضل.
لو في inferior thinning والانفيريور ثيننج ده مفسر كلينيكال وانا بفحص المريض واخد بال حضرتك، هل ده يسمح لي برضو ان نكسر القاعده وممكن نعمل له سيرفيس ابليشن او وات ايفر؟
Sure. I think you joined later. انت جيت متاخر صح؟
دخلت متاخر.
دايما يا عزت كده ماشي. لا احنا قلنا يا حبيبي ان احنا we have to correlate the finding of the pentacam with the clinical data of this patient, of the same patient on the state lamp. You bought the patient and bought the topography and the pentacam beside the patient. Yes. Yeah. Okay. You put the patient and the pentacam beside, and check the same point of abnormality in the pentacam on the cornea, on the state lamp. If you found in a scar in this cornea, and a lot of patients, we may find the scars in the cornea, post-traumatic, if superior post-trachomatis, and so there post-foreign body, there is nebula in this cornea. This will explain the abnormality, and it can go for refractive surgery.
Yes, sir.
If you are away suspicion of corneas, you can go for refractive surgery if the other factors are provided. Okay.
Yes. Right.
The first question I will discuss it with you after some slides. Okay.
معانا دكتور عبد الباسط تاني وعمرو راضي، اسئله ممكن؟
اوكي، بس انا مستسمحك في بلو دوتس كده، في بلو درو لاينز وريد من عندك، ممكن تشيلها؟ اتفضل يا عباس.
حاول بس. تمام.
حسام ازي حضرتك؟
الحمد لله يا حبيبي.
في حاجه افضل لو انا I have a patient with thin cornea حوالي 450 وفي refractive error مثلا في عين -2 diopter والعين الثانيه -1.5 diopter. البيشنت need to do refractive surgery وعايز يعني to remove the glasses. هل انت البيشنت ده حضرتك تنصحه ان هو يعني to go for phakic IOL or to advise him not to do any refractive correction because this refractive error is too small to avoid the phakic IOL complication?
The thinnest location is 450.
Yes.
Yes. It's out of the accepted thickness for refractive surgery. Even if the refraction is just -1.
Yes. انا بتكلم على الفيكك ايول، هل ده يمشي في سكه فيكك ايول والكومبليكيشن بتاعتها وفي نفس الوقت الايرور بتاعه يعني سو سمول يعني، ولا انت رايح حضرتك؟
How many? Excuse me. How many error? How many degrees?
-2 diopter in one eye and -1.5 diopter in the other eye.
This patient is for contact lens or for glasses. I don't think I will not advise this patient to do any refractive surgery. -2. No, we have to advise the patient to be away from the refractive surgery, and I think you will agree with me that the rate of complication expected after the phakic IOLs.
بس عشان كده فعلا.
The harm you should weigh the harm and the benefit.
صح تمام.
This patient with very low error. So advise him for the contact lens or for the glasses and don't touch.
Thank you.
Not at all.
معانا عمرو، معلش يا باشا.
عمرو.
معلش يا فندم بعد اذن حضرتك، بس بالنسبه للكورنيال اوباستي ايفن حتى لو كانت فنت اوباستي او كده، تاثيرها على البنتكام بيكون في ايه بالظبط؟ هل مثلا بيكون تاثيرها على كل البارامترز بتاعه البنتكام بما فيها الثيكنس ماب والاليفيشن مابس والبي ريدنج، ولا بيكون على حاجات بس معينه في البنتكام يعني؟
Yes, let's agree first that the pentacam is a mirror image like. It will overcome the opacity. It will pass through the opacity, but with less transmission. So it will be affected as the corneal surface, the corneal thickness, and the elevation maps. It will be affected topography, Paki, and maps. So you will get in this patient steep curvature, you will get thin pachymetry, and you will get false high elevation in the anterior and the posterior surface of the cornea. So this patient is candidate for OCT. The anterior segment OCT will measure more precise and accurate and accurately the corneal thickness instead of the pentacam to get the real thickness of this cornea and the scar point. The OCT is more precise and more accurate. And so there's a new device now with both pentacam and OCT to measure such situations. Okay.
تمام، شكرا يا فندم.
عفوا. لكن زي ما قلنا كده وجاوبنا مع دكتور عزت ان انت if you find the scar and you could diagnose the suspected or the expected causes of this scar, it is not the scar of the corneal protrusion of the corneas. It's not the hydrates. It's not the high drops after a corneas. If this scar could be like post-traumatic or post-surgical, you can go for refractive surgery if the other factors are allowing you to do that. The pachymetry map, the three or the 4 points which I have mentioned are so crucial to correlate. And don't forget all the time to inter-eye, to do the inter-eye comparison, to correlate the both eyes together. So when I send the patient for unilateral LASIK, I always ask for bilateral pentacam to correlate the inter-eye asymmetry or symmetry. As we said here, correlate the apex of the cornea to the thinnest location and the difference between them. You have to correlate on the back of cornea the thickness in the superior and the inferior points of the cornea shouldn't exceed the accepted range, which is from 30 to 35 micrometer. If you find a thinning in the inferior cornea, which is far away from the superior part of cornea, you have to suspect even if it's still at the same range, at the normal range. If you found a patient with inferior pachymetry map showing a point of 500, and in the same point superior, it's 540 at the same circle at the same point, it could be suspicious because the accepted range or accepted difference between the superior and the inferior points in the pachymetry map is within 30 to 35 micrometer, respecting the difference between the superior and the inferior cornea. Also, we have to study the figures in both eyes to correlate the thickness of the cornea, the thinnest location in the right and left eyes. And the difference should be within a limit of 15 in some textbooks, and 15 micrometer, and maybe less than 10 micrometer difference between the thinnest hair and thinnest location in the other eye. So there are 4 factors: the difference between the elevation, the difference between the thickness, the steepest K, and the otherwise normal eyes should be close to each other. It shouldn't exceed the accepted range, otherwise you will discuss. Yesterday, I have a meeting with a lot of clinical cases and discussions about this issue, and the presenter showed identical twins. And in the identical twins, we found that one of them has in her eye inferior steepening, which is more than the other eye. Inferior steepening, which is far from the other eye, but both are in the same range. But the inferior steepening in one eye could suspect the early corneas in that eye, because the correlation between the both eyes together. If we check this eye separately, we will consider this eye as a normal eye, as a normal eye, okay? While in correlation with the other one, they found that the difference in the curvature between both eyes, the difference between the pachymetry maps in both eyes are out of the normal and accepted range, so they could diagnose that this is a case of early keratoconus. So please study both eyes and correlate with each other. Create the four figures with each other, and you can suspect and you can consider this patient a suspicious one if you found that the difference between the pachymetry map, for example, is more than 15 micron in both eyes. Okay. Can we go now for the clinical cases to show what we discussed? عيد معايا عيد.
ايوه يا فندم، معاك يا فندم، اتفضل.
This is the first case. This is a clinical case. Yeah, this is my case, one of my patients. She came to my clinic with a rapid decrease of vision or a marked diminution of vision. I found that with after getting this pentacam that the key 1 is 49.1 and the key 2 is 49.4. So the difference is so insignificant between both, but still the same and steep. Dr. Mahmoud Khalil, لو معانا. This patient is 49.1 and 49.4, which is more than 49. This is the K1 and the K2 on the side. But if you check the steepest points on the map, you will find that there is a point of 51.1, which is the key max. The key max in this patient is 54.4, and the same circle, you will find that the superior point is 44.6. محمود خليل معايا؟
ايوه يا فندم.
ايوه موجود دكتور حسام.
أنا في center of this cornea. The superior part of the cornea is 43.9. The next point is 40.3. The next point is 44.6. The crossing the center going to the inferior part, you will find the same point at the same circle is 54.4, right? The next
Right.
is 50. So if we measure the mean K, we will decrease the effect or the impact of this center point.
Yes.
لو احنا حسبنا 40 44 المين بتاعهم مش هيبقى matching مع ال 45 and
Yes.
in the same. So the same point, the same circle is considered. So the difference is high. Q1 and Q2 on the sidebar, you will find it 49.1 and 49.4. But the key max is 54.4 at the center of the cornea. So I have to consider that this patient is abnormal one, is totally abnormal without any thinking about the difference between the superior and the inferior points. Especially the steepening is central and inferior. And it's more central than the inferior point, if you are saying now.
Yes.
Okay.
Okay.
The astigmatism is so insignificant. It's minus 0.3 because the difference between the Q1 and Q2 is so little. So this patient is keratoconus patient, right? I think all of you agree with me. But in such patient, you will do any refractive surgery? Absolutely not. But don't discharge this patient. I found most of patients are coming after checking for refractive surgery and they discharged. They were discharged from the clinic or from the center, unfortunately, without any advice. you are not suitable for refractive surgery, still with your glasses and go away. I think we have we have the responsibility to treat this patient. If you find a patient abnormal or find a patient who is not candidate for refractive surgery, it's not a good thing or a good behavior to just discharge this patient and say, come for follow-up after 6 months or 1 year and so. Because most of our patients are not aware enough about the problem. So you have to pay attention and pay time for this patient to educate him about the danger of the keratoconus, the danger of the ectasia, to be alert about his eye and come to you again if you find any suspicious case. But in such case, I have to go directly to treat the keratoconus. What's your opinion in such a case? What will you think to do? Yeah, it's open for sharing.
Dr. Hassam?
Yes.
I will ask to check the other eye of the patient.
Yes.
And I will check clinically the best corrected visual acuity.
Yes.
And I will correlate the visual acuity of the patient with this topography.
Yes.
After this check and after checking the other eye, I will have two options, either to follow up the patient or to have a cross-linking, but with correlation with the clinical data of the patient and the other eye.
Okay, but I think we may find it as strange that the difference, the astigmatism in this patient is negligible, right?
Yes. Yes, right.
We used to see or to find high astigmatic error in keratoconic corneas. Okay, but if the refraction of this patient, if the refraction of this patient is -8 sphere and -9 cylinder on the autorefractometer.
Yes.
And the best corrected visual acuity for this patient was 660.
Yes.
And the other the bachymetry map and the elevation are within good situation. The thickness is more than 500, and the elevation is still within the range of +30 or +25 about the posterior elevation. And someone is drawing on the screen now. محمد عيد، برافو عليك.
لا يا فندم، هي المفروض من عند حضرتك انت بس، يعني الشير تمام.
ما عملتش انا حاجه على فكره. خليل
امال ازاي؟
نكمل يا محمود خليل.
مع حضرتك حسين.
The best corrected is minus. Best corrected is 660 with -8 and -9 cylinder.
Yes.
By the autorefractometer, not by the topography at all.
Yes.
Will you think in corneal ring in such patient, or to do cross-linking?
Okay, so this patient has extremely irregular cornea. The astigmatism not shown on the screen because there is some points of steepening, some points of flattening.
Yes.
So it is irregular cornea. So I think the intracorneal ring segment, if I implant an intracorneal ring segment, the results are not correctly expected.
Yeah.
So to me, I will go for cross-linking, just cross-linking.
Cross-linking to fixate or to stabilize the cornea.
Yes. Yes, to just stabilize the cornea, but I think intracorneal ring segment is not an optimal option treatment for this patient.
Because of what, in your opinion?
Because I have irregular cornea. I have irregular cornea. In the same circle, I have K reading of 45.6. In another point on the same circle, I have 50 diopter 0.1. Supporting the ring will not smoothen the cornea. In my opinion, will not smoothen the cornea in the same level in all points. So after putting the ring, 1 point will flatten, 1 point with more flatten. So I expect to have also a regular cornea post putting an intracorneal ring segment, but still it is an option.
Yeah, okay, it's a very good opinion, despite of the intracorneal rings being used for regularizing the irregular cornea. It's not a matter of irregular cornea, but of the non-understood corneal protrusion, because we used to see a corneal astigmatism. The corneal astigmatism in the topography is insignificant. So
null.
what will be corrected by the intracorneal rings? Okay, I'm with you.
Again,
I agree with you. Despite the corneal, the intracorneal rings are used always to correct or to regularize the irregular cornea, but it is not classic irregularity in this cornea because the topographic corneal astigmatism is insignificant. So we are not sure about the autorefractometer astigmatism, which may be related to other parts.
Yes, I mean this.
Yes.
Yes, I mean this.
Okay, but this cornea could be with other problem than the conus. This is differential diagnosis of that cornea. I just need to do brainstorming together for the all participants. Differential diagnosis of this cornea. This cornea is conus, or what else?
One of the participants.
نعم.
Okay.
حسام.
نعم. نعم محمود.
حسام.
نعم حبيبي.
Always I will put in suspicion that this patient has a scar in this area.
Perfect. The very good supposing.
Dr. Okasha supposing lucid maybe.
حبيبي. But don't listen. Absolutely, and don't discharge. The second case. What's your opinion on studying this pentacam? What will you decide after the slides we talked about? The key one is 44.6. The key 2 is 48, right? The key max is 50.1. 50.1, the key max. The bachymetry, the thinnest location is 514. The Becky apex is 523, which is still within the accepted range. The difference is not more than 10, is 11 actually, borderline. The y coordinate is minus 1.2, right? The elevation within the accepted range. Anterior elevation in the superior. This is the OD, the right eye. So the nasal part is with high elevation, high anterior elevation, but the back elevation is good. Well, I think if you remember that I said at the start, correlate the anterior elevation with the posterior elevation. If they are both high, consider. If they are not, don't consider, and think in other reason for that. Yeah, I'm waiting for your diagnosis and decision. This patient came to me for seeking for refractive surgery. خليل كان سألني أسئلة ليها علاقة بالتوبوغرافي ده.
Yes.
وعمرو راضي. But I need to hear from you.
دكتور حسام, refraction and best corrected visual acuity.
Very nice. Okay, the refraction is +3, sphere, -1.5 cylinder. The unaided visual acuity is 636. The best corrected 6.9.
Okay. Okay.
Yes.
Dr. Hassan.
Yes.
So the abnormality in this topography is في سن decentration, في displacement resistance location in the y axis.
Yes.
I have just steep cornea in the steep cornea. K max is 50 in the upper cornea. The opposing to it is depression. So I suspect this is just atrachomatous bonus.
Yes.
Is present in this patient.
Okay.
But still, I have a central key reading 48.3.
Yes.
And in another point 44.9 flat. So
Yeah.
I have some irregularity of the cornea. I think it is related to the trachomatous bonus present in this patient. So if I will go for a corrective refractive surgery,
Yeah.
I will go for PRK.
You will go for PRK, even if you have a y coordinate of -1.2.
Yes,
1.2.
it is a point of suspicion, but the patient is still having a good best corrected visual acuity, and this is all
the same
still having a
excuse me, at the same point of the thinnest ligation is steep, which is 48.3. The anterior elevation is with minus, and the posterior elevation in that point with minus. But you will go for PRK, right?
Right.
Okay, even with the hyperopia, do you like the PRK with the hyperopic correction?
No, PRK. I have a bad experience with the PRK and hyperopia. Haze, much haze. Regression, not so good.
Yeah. Okay. Another opinions?
عمرو عنده رأي.
وبعد إذا حضرتك فندم بس بالنسبة للبنتكام كده، أولا في الكي ريدنج يعني هو في شوية في سكيونج، يعني يمكن أقل من 22 درجة تقريبا، بس برضو يعني لو هنتكلم بريسك فاكتورز يعني بتاعت الريفراكتيف سيرجي يعني، فانا عندي السوبيريور ستيبنينج اكتر من 2.5، في فرق بين 44.9 و 49.5، فده ريسك فاكتور بالنسبه لي. الانتيريور اليفيشن ماب في برضه موجود، والواي كوردينيت في الثينست لوكيشن.
يس.
فدي حاجات يعني تبقى يعني كده ريسك فاكتور موجود عندي، فالبيشنت نوت كانديديت فور ريفراكتيف سيرجري بالنسبه لي يعني.
اوكي. If you will stop at the pentacam, the sagittal curvature or the topography is not well. So you will explore this patient and don't do any refractive surgery because of these figures, right? Figures.
Okay.
According
to risk factors of this pentacam, yeah.
Yes, which is signed. Look at the black ovals and the circles. The superior circle bordering the highest points of the highest case, 51, 49, 49.5. Okay, the inferior, which is opposite to the superior, is 48 and 44.9, which is so far there is a high difference between both. Up till now, it's irregular, but I have a question from Dr. Okasha at the start. We may have a regular pentacam, but it's not classic to be considered as a conus, a regular bow tie. If Okasha remember the term, which is noisy cornea, which is irregular or irregularly drawing cornea, like that, there is steepening part steep part in the superior, good center, steep part in the inferior without connection between both of each other. So it's a cornea of the irregular surface. It's not the irregular cornea. It's different names. This is cornea with irregular surface, not regular cornea. Okay?
تمام يا دكتور كيشا.
With me the same. And you asked me about something like that. The second that the inferior, the posterior elevation, which is coinciding with the inferior part of the cornea is not high. So it's not expressed as a weak cornea or keratoconic topography or cornea. The same in the posterior elevation and anterior elevation. There is minus. There is no plus. There is no protruded. The pachymetry, the corneal apex is 523, and the thinnest location is 514. The difference is 9. It's not far. The thinnest location Y coordination is minus 1.2, but look here, the Kmax where? So my dear colleagues, we have to correlate the thinnest location with the Kmax. This is an important point I want to see. I want to emphasize on it. The thinnest location Y coordination is minus 1.2, but still away from the Kmax. The Kmax is plus 3.02. It's shifted up. It's shifted up. The Kmax is so superior. It's totally away from the thinnest location.
Yes.
It will be more suspicious. It will be more guiding if you find the Kmax is almost at or close or near or around the thinnest location deviation. Okay. So up till now, it's at irregular cornea, but not keratoconic cornea. So I will go for refractive surgery, as Dr. Mahmoud said. But to skip the problems of the PRK with the hyperopia, I will do flap. I will create a flap. Because this is the image of the patient. This is the photo slit lamp captures for the patient. Look at the center. You will find a faint opacity crossing the pupil, crossing the center. This opacity extending from the superior cornea down to the pupil. So it explains all that irregular points and the steep points in the cornea. This patient's age is 45 and stable refraction and good best corrected visual acuity, and with these faint opacities in the cornea, which helps you accepting the irregularity of the corneal surface and the steep points, which is beyond the normal. So you can go for refractive surgery because it's explained that all irregularities are explained. The cornea is not thin, the cornea is not weak, but the corneal surface is irregular, and so we can go for refractive surgery. But I have done a flap. When I created the flap, I captured this image for you.
Yeah.
Look here.
There is the bit.
Look here, yeah. Look here at the green circles. You will find the scar.
Yes.
This is the points of scarring, which is removed with a flap. This is the point of the scarring in this part of the stroma of the superior stroma, and this point is explaining the thinnest, explaining the steep, explaining the shifting of the all figures, ups and downs. So this is the flap, and this is the bed showing these scars or after scars. So the all irregularities are explained now, and I could go for refractive surgery. This is the flap. I'm removing it now. I'm checking for any attached particles or buttonholes, but there is no. There was no any irregularities or any problems with the flap. The flap thickness planned to be 110 with the X90 micro Moria, because I like all the time to get a thinner flap, and I was not worried about anything. As you see, the bed is okay, but showing the scar depressions. Okay, there is no need for the completion of the video because of the laser ablation. Drawing